Hi, welcome back to Pharmacology. Today we'll go through the congestive heart failure treatment. So, this is only going to be a brief overview for a true in-depth, lecture about congestive heart failure and cardiac output in general. Go to the physiologic lectures. But there's two different types: systolic, where there's a problem with contractility, the heart is going to be dilated; diastolic, where there is going to be impaired filling because there is no relaxation of the heart. So in both of them, there's going to be insufficient cardiac output, but different mechanisms. Insufficient cardiac output is going to be a problem with oxygenated blood, increased venous pressure, and systolic is more in younger patients. Diastolic is more in older patients. It's restrictive. It's not as common, but forward output or forward failure is going to be reduced output, or there is there's a problem with contractility. Backwards failure is diastolic dysfunction, and there's a problem with filling. So the backwards failure can be problems from like pulmonary congestion feeding back into the left atria. And then from there, it's going to be left ventricular failure. So with a systemic resistant, there's going to be hypoxemic ischemia encephalopathy. This is the problem that we are most concerned about. So there's going to be, that's going to be called cor pulmonale, where there's problems with the lung leading back into the heart. And that's left-sided heart failure. And right-sided heart failure, there's going to be problems with the systemic system. So there's going to be edema, renal failure, and ascites. So all of this blood is pooling. There's not going to be a decent venous return from the body organs. So the problem with right-sided heart failure is it's going to back up into the end organs. So it's going to make the venous return worse. And with the right heart failure, it leads into left heart failure. Like I said, there's cor pulmonale when there is the lungs feeding back. Okay, so there's two different classes. There's the NYHA class, and then there is the staging class. So they're kind of the same. Stage 1 or class 1, there's going to be some structural myocardial changes and breathlessness with some activity. Stage 4, there's going to be heart failure at rest. Okay, so in compensation, at first, it's going to work. The sympathetic system and the renin, angiotensin, aldosterone system is going to increase the blood pressure, and by that, it's going to increase the cardiac output. So first, it's going to work because of the Frank-Starling mechanism. So with more blood coming into the heart, the greater the venous return, the greater the contractility. And that's going to be able to work for a little bit. Perfusion is going to be okay, and this is only a mild rise in blood pressure. But over time, there's going to be myocardial hypertrophy, and that's the remodeling. So the hypertrophy occurs because of the apoptosis, oxidative stress, ion gene channel expression, and ischemia, and all of that's going to happen. So it's going to do that in response to the cardiac output. Okay, so the Framingham criteria, there is the major criteria. So jugulous venous distension, paroxysmal nocturnal dyspnea, so problems with breathing at night, cardiomegaly, acute pulmonary edema, S3 gallop, and increased venous pressure. Minor edema, night cough, dyspnea on exertion, hepatomegaly, and pleural effusion, as you can see here, and tachycardia. So the diagnosis for the Framingham criteria is 2 major criteria, or 1 major and 2 minor. That's a little bit like, it depends on the clinician, right? So that is up to some debate. However, what is not up to any debate is the labs. So in heart failure, ANP and BNP are going to be increased. Okay, so what do we use? We use ionotropes to help contractility, diuretics to get rid of the edema, vasodilators to reduce the blood pressure, beta blockers in order to slow the heart rate down and also increase the contractility. So what's important? The remodeling inhibitors, the ones that will increase the lifespan of these patients. So spironolactone, ARBs, ACE inhibitors, and beta blockers. These are important. So spironolactone, potassium-sparing diuretic, ARBs, ACE inhibitors. So it's going to slow down the RAAS system, and the beta blockers are going to help with the heart. So these will antagonize aldosterone and, like I said, inhibit the angiotensin system. Dapagliflozin is a SGLT2 inhibitor, and that is going to be used for osmotic diuresis. Neprilysin inhibitor will inhibit the degradation of the natriuretic peptides, so BMP and ANP, and those are good because those will help the vasodilation, right? So we want these to stay around. The medications are sacubitril and valsartan. Okay, so the cardiac glycosides are digoxin. The beta agonists are going to be dobutamine and dopamine. The PDE3 inhibitors are enamorone and milrinone. Diuretics used are going to be your loop diuretics. These are the most efficient, remember. The thiazides, you got to be careful because these can also affect calcium balance. And then the potassium-sparing diuretics. The vasodilator, remember hydralazine is arteriole, and venous dilators are going to be your nitrates. So what works on both arteriolar and venous vessels are the ACE inhibitors, the ARBs, and our emergency drug, sodium nitroprusside. Digoxin. Digoxin is mainly used in African American patients with persistent hypertension. It's very efficient for them. It's not as well tolerated in Caucasian males. For some reason, digoxin is very, very toxic to Caucasian males. This is okay to use in acute, cases, but management-wise, the length of life is most definitely shortened in a male or in a white male. So ditch is used to treat heart failure and atrial fibrillation, and like I said, there is toxicity that occurs, and it increases the force of contraction by inhibiting the sodium potassium ATPase, and by that more calcium is going to be accumulating in the cell, allowing more contraction to occur. So it also increases the vagal discharge but decreases the sympathetic activity at the toxic doses. So in general, it will increase the vagal discharge, so increase the parasympathetic system, but it also will switch over and cause tachycardia and arrhythmias at high doses. Okay, so toxicity, let's say bradycardia at first, and then it will switch over. But GIT is going to be the most common site affected, so it's going to result in nausea, vomiting, diarrhea. There's going to be central nervous system effects, vagal and chlorothiazide stimulation, disorientation, hallucination. There are the visual disturbance, and the vision is going to be very yellow. So important to know because this is the ones that the patients can report. Okay, so digoxin is a particular drug. There's a lot of interactions, so we don't want to use it with loop diuretics, thiazides, due to hypokalemia, hypercalcemia, and hypomagnesia, because all of these will enhance digoxin too much. So remember, digoxin is going to increase intracellular calcium, right? So a thiazide will increase the calcium, and all that's going to lead to a heart attack, really. So that's bad. Potassium, on the other hand, will inhibit binding of digoxin to the NAK-ATPase enzyme, so it's going to decrease the efficacy. Antacids, sulforaphate, and enzyme inducers are going to decrease the digoxin efficacy. Why? Antacids are going to increase the pH and prevent the absorption. Sulforaphate, same thing. Enzyme inducers are going to increase the digoxin metabolism, so more of the digoxin is going to be excreted versus being able to be freed and used in circulation. Okay, so what happens if you do get an overdose? So first, we want to stop the cardiac arrhythmias. We give a potassium infusion to inhibit the binding of digoxin to the sodium-potassium ATPase. But in acute digoxin toxicity, we don't want to give a high dose of potassium. Why? It's going to give the patient a heart attack. What do we do instead? We give lidocaine or phenytoin. And there is Digibind. So Digibind is a digoxin immune FAB, and that will bind directly to digoxin. Beta agonist. So remember, there's the one that you need to know: beta 1, beta 2, beta 1, one heart. So this affects heart, two lungs. The receptors are going to be in the lungs. And dibutamine, it's a selective beta-1 agonist, and in higher doses, it can also stimulate the alpha-1 receptors. So dopamine is going to work on the D1 receptors in the kidneys and B1 receptors in the heart. And at even higher doses, it will also activate A1 receptors. So because of that, we do not want to give more than 10 milligram per kilogram per minute. Phosphodiesterase 3 or PDE3 inhibitors are enamorone and milrinone. And those, by inhibiting PDE3, it's going to increase the amount of CAMP, there's more phosphorylation, and more calcium. So it's going to prevent the CAMP degradation to AMP. So more CAMP around, more phosphokinase, more calcium, more contractility, more vasodilation. However, it's not stable in a dextrose solution, so it's a pretty sensitive or fragile solution. Good things in these bad times: PDE inhibitors are pretty useful against COVID-19 because it's going to increase CAMP, and it's going to help with all of these problems, because we want the smooth muscle relaxation, we want the airway nerves to relax, and we want to decrease inflammation, decrease remodeling. So good stuff. Beta blockers are going to be used in stable patients, and it's contraindicated in acute cases because of the excessive tachycardia and the other effects on the heart. So it's going to decrease the heart rate over time, decrease the amount of renin, and decrease the remodeling. Always remember the cardiac remodeling antagonizers, preventers, there we go. So the other one, ACE inhibitors. The newer vasodilators, nesiritide, will increase BMP, so that's good. More vasodilators. The adverse drug reaction is going to be hypotension, of course, but renal toxicity is something that we need to watch out for. Aliskiren is the renin inhibitor, but there's a lot of CNS effects, so not that popular. Bosentan is an endothelin antagonist, and dapagliflozin is SGLT2 inhibitor for heart failure with reduced ejection fraction. Sacubitril is going to be a neprilysin inhibitor, and it's going to inhibit natriuretic peptide degradation. How do we manage heart failure? We give furosemide as your diuretic. You also give hydralazine or nitrates for your arterial or venous dilation. Dobutamine and dopamine to bind to the kidneys in order to reduce the amount of renin secreted. And in pulmonary edema, we give ONFM, which is oxygen, nitrates, furosemide, and morphine. How do we manage chronic heart failure? So first thing, we want to reduce the workload of the heart. So it's a lifestyle change. First, start with diet, reduce the weight, and then we start giving the ACE inhibitors, the ARBs. Once they're stable, we give beta blockers and then a loop or thiazide diuretic. And you give digoxin for an acute, just a little bit, because the toxins build up in the heart for a period of time if AFib is present. And then you add the spironolactone, your potassium-sparing diuretic. And then you can also give hydralazine or isosorbide dinitrate. This is more popular because it's cheaper. Okay, so that's it for now. Thank you for your attention and good luck studying.